Hello, everyone. I hope everybody's week has gone well so far. And welcome to another round of It's Worth a Shot. This week we will have Dr. Koo on for Decolonization, a strategy to reduce healthcare associated infections. Excuse me, next slide, Mary. So a disclaimer, because we do have a third-party person on, this presentation may contain information and or content supplied by third parties. Information provided does not constitute endorsement or recommendation by Mount Pacific. Upcoming events, we've got quite a few for you. Center of Excellence has a Understand the Science of Addiction and Recovery that is happening next week. There's also a Farm America guide, what senior living operators need to know, and a patient safety and quality healthcare regulatory update, what you need to know about the latest changes affecting patient safety. Next slide. Also, our friends in Hawaii are sharing a age-friendly health system on-demand module. This is a fantastic resource, especially since I know a lot of our areas are kind of deserts when it comes to dementia and age-friendly trainings. So please utilize that link and the QR code on there. And yes, Hawaii is putting this on, but this is open to everyone. So please utilize and share as much as you would like. Next slide. And then lots from NHSN. So we have the newest newsletter, if I can use my words today, was released. That's that first link. And then we also have a up-to-date definition changes for COVID-19 vaccination reporting beginning on September 30th. Individuals consider up to date if they have received a single dose of the 24-25 updated COVID vaccine. So as of the end of this month, that definition has changed. Again, we have some pharmacy partners that we can help with in your areas. So please reach out to your camp manager if you need help setting up some sort of vaccine mobile clinic, or if you just need more handouts. Next slide. And then also from NHSN, we have long-term care facility respiratory pathogens module. That's a lot there, so I'll let you kind of read. You don't have to listen to me ramble through. The first one is coming up on September 24th, and there will be 2 replays given in early October. Next slide. And 2 more in October for personal level vaccination forms. So if you have questions on those, please let us know. And these links will be shared out with the slides available, I think, by next week. If you need them sooner, please let us know and we'll get them in chat for you. Next slide. Housekeeping items. Add your webinar topics or clinician ideas that you would like. We do these webinars for you. So if there's something you want us to talk about or something that's just bugging you, we want to know about it so we can touch on it. And we don't know what we don't know for what you guys need. So please let us know. Next slide. So 'tis the season. We are in flu season now. So our weekly snapshot is still kind of low just because we are in the beginning, but as every year we'll probably start to see it climb a little bit. Next slide. COVID, same thing. We're getting in that time of year. We're going to start keeping an eye on this for you all. There was a change from prior week of -8%. Good job, guys, on your infection control and your mitigation strategies. We appreciate that. If you have any questions or you need just some help, some mentorship with your IP system, please let us know and we'll give you a hand with that as well. Next slide. So now I'd like to introduce Dr. Koo, and he will go over decolonization with you.
Thank you very much. I actually wanted to just kind of comment about the COVID-19 numbers. So here in Montana, we're actually still seeing a fair number of cases, at least at the Billings Clinic. We're about 20% test positivity. So it's certainly still around, even though for most of the state country, it may be on the downhill, but we're still maintaining a fairly high level of test positivity and hospitalization. So, but today I'm actually not talking about COVID-19. I am actually going to talk about decolonization as a strategy to reduce healthcare associated infections. So for those who, my name is Neil Koo. I am actually an infectious disease trained physician. I serve as a healthcare epidemiologist. For those who are not familiar with what those are, they usually are an ID trained physician who primarily focus on healthcare associated infections. And so, which is really kind of why I put together this talk. And a lot of what I do is to work with our infection preventionists to look at incidents, causes, as of what and contributing factors to healthcare associated infections, and what we could do to mitigate and those factors to reduce those incidents. So anyway, next slide, please. So just quickly, we're talking about decolonization, and I will kind of define that in a subsequent slide. But I want to kind of give a little bit of background about why we're doing decolonization. And to start off with is the pathogen that we commonly look at when we targeting when we're just talking about decolonization is Staphylococcus aureus. And I know we hear about this a lot because even here at Billings Clinic, we actively do surveillance testing on all our hospitalized patients for MRSA. And we know that and I'm sure many of you are already familiar with all the things that this pathogen can cause. But just want to let you know that this is a very ubiquitous pathogen. It's pretty much everywhere in the community, in the environment. So it's not so much as something that's specifically that I are encountered in a healthcare setting. And even though we like to think of this as a really bad pathogen, it's actually a part of our microbiomes, and it's certainly on our skins and such. And so it's really commonly found in the upper respiratory tract and the skins. What we see is commonly is that there is something that this pathogen unlike something like anthrax or even just like COVID-19 or SARS-CoV-2 and influenza, it causes infection when their opportunity arises. So it's not always something that everyone with Staph aureus. Screen positive for Staph aureus will have infections, but when there is an occasion, whether there's a break in the skin, which is probably the most common cause of Staph aureus infections, or other factors like implanted devices or decreased immunity, takes advantage of that situation, and it has multiple virulence factors. And once it gets caught and once the infection starts, cause a really serious reaction. So next slide, please. Now, how common is Staph aureus? And it's actually fairly common. And depending on which surveillance study you're looking at, it ranges between about 20 to 35%. So a huge number of the community actually carries this organism on their skin. And most of those patients don't develop infection due to this pathogen unless there's some of those reasons, as I kind of pointed out. Next slide. And now, coming to this is why we're having this discussion is because this is a chart of published back in 2014 of all the pathogens that are commonly associated with healthcare associated infections. And Staphylococcus aureus, next slide, which just click, it should highlight, is number two, and certainly C. difficile infection is the number one, and that's no surprise. But the second most common pathogen is Staphylococcus aureus. And next slide. And where it causes infections are, where we commonly see surgical site infections, bloodstream infections, and pneumonias. So certainly there is some concern that this as being identified as one of the more common causes of healthcare associated infections. And therefore, we're looking at different ways to approach how do we mitigate these risks of those infections. Next slide, please. And there are multiple studies have identified risk factors. That colonization of Staph aureus on their patient will actually can lead to potential infections. So these are just multiple studies looking at specifically in an intensive care unit where ICU patients who are colonized with Staph aureus are more likely to have infections or healthcare associated infection associated with Staphylococcus aureus. Next slide, please. And this is not just limited to just ICUs, but also other areas in the healthcare system on the hospital floor, and as well as those patients who are undergoing dialysis. Next slide, please. So, and even though we are focusing primarily or have been focusing on hospital-acquired infections, detection of MR Staph aureus in patients who have been recently hospitalized also lingers after they're being discharged. Next slide, please. And this is a graph that from a publication about a little bit over a decade ago, and showing that patients who have been screened positive for MRSA continues to have risk of infection and other, not just to MRSA, but all other causes. Compared to those who are not screened positive with MRSA. So next slide. And as you see, there are a couple of other risk factors associated with it. Next slide, which are particularly age, those with diabetes, those with kidney disease, and definitely with those who have been undergone invasive procedures, such as placing an intravenous catheter or undergone bronchoscopy. And certainly these are the patients who are having diabetes and chronic kidney disease, they're probably already have those invasive procedures done for the sequelae of those diseases. Next slide, please. So with all these findings, the question is what can we do to mitigate this? And why is the colonization a strategy we can consider? And this kind of stemmed back from couple of decades ago, where we had looking at managing patients with recurrent Staph aureus skin and soft tissue infections. And IDSA had previously published some practice guidelines addressing that, where they tried doing decolonization is a strategy to consider to reduce those patients who are having frequent infections. And there had some good results with that. But also, that got extended into looking at other type of infections associated with Staph aureus, particularly surgical site infections. And the two areas that really have been looked at where decolonization have been very effective are those patients who are undergoing cardiovascular surgery or prosthetic joint replacement surgery, such as prosthetic knees and hips. So, next slide. Now, as I'm kind of talking more about decolonization, probably good. I'm going to take a moment just to describe, at least to make sure, explain what decolonization is. And decolonization is really temporarily reducing a patient's skin microbial burden to reduce, with an effort to reduce this risk of infection. So, and then again, as I mentioned, most of the studies really been focused on Staph aureus. There's some study looking at other pathogens, particularly gram-negatives, but the brunt of the study, if you go on PubMed and type in decolonizations, I would say greater than 90% more focus on Staph aureus. Now, the way that we accomplish most of the studies are looking at to do decolonization involves applying some antiseptic or antimicrobial agent that either primarily is intranasally, but also with or without a topical agent that's being applied for a varying duration. And I comment on that because for a couple of reasons, that there's not a standardized practice, a protocol on how decolonization is done. Although many studies have very overlapping practice, and I have outlined them in subsequent slides of what they do. But just to let you know that it's there are varying degree based of duration of application based on the disinfectant or the antiseptic that's being used. Next slide, please. And before I start kind of going into a little bit more of the studies, I also want to kind of highlight just some of the strategies that are being have been employed for decolonization. For many of us, I think we're more familiar with the targeted approach, where we do an NMRSA screening of a patient, or either for a hospitalization or for our anticipation for a surgical procedure, and then we would then decolonize those patients who are screened positive. And certainly, there's pluses and minuses to that. Costs may be part of it, but there's also listed statistical challenges, and especially like I will just speak from experience I've had in Billings Clinic, where many of our patients don't come in if they're being screened for surgical procedures, making those arrangements may be a little challenging logistically. The other strategy that's been looked at is universal. So instead of just trying to identify those patients who have been screened positive, we're just going to do the decolonization process to all the patients. And there are advantages to that, and particularly don't have to deal with doing the screen testings and such. But yeah, this means that because every patient who are either getting hospitalized or being admitted or scheduled to have a surgical procedure, there may be some extra costs involved in that, because we're just blindly doing it on every patient that would fit those conditions. So, next slide, please. Now, so I'm just going to go through a few of this evidence and kind of looking at studies that looking at using decolonization as an effort to reduce healthcare associated infection. And this first is a systematic and review and a meta-analysis looking specifically at ICU patients. And so what they're found is that all the studies that they have reviewed, next slide please, have identified that for the vast majority of patients who have been decolonized, there is a significant reduction in bloodstream infection, central line infection, ventilator-associated infection, as well as any other associated infections, particularly in those bugs. Obviously, decolonization will really will not affect counties because there's a totally different pathogen involved, and as well as C. difficile. So next slide, please.
Dr. Koo, we did have a question in chat, and
sure.
The question is, does universal decolonization lead to increased resistance?
That's a very good question. So far, there probably the area that's been had some discussion about is the use of mupirocin as an antiseptic for a nasal decolonization. There have been some reports, clinical reports that have shown that there are some reports of resistance to mupirocin. So now how that translates clinically and the incident of that is really unclear. Certainly, I will say that looking at that, even though it's brought up as a concern, and it's commonly brought up as a concern by infection preventionists for a variety of reasons, which I'll get shortly to, as well as pharmacists and such. This hasn't seemed to have it hasn't made an impact in the suggestion of using mupirocin. Now, there are other agents, and certainly depending on which antiseptic is being used, if you're using mupirocin, using propionyl iodine obviously would be an alternative because they're not the same mechanism. Furthermore, again, these are not true. These are the antiseptics that are being used are not also used as a systemic antibiotic. So there's no cross reactivity. So even though there's may have some reported mupiricin resistance, doesn't mean that antibiotics to treat MRSAs and such that will increase resistance to antibiotics commonly used to treat MRSA infections. Does that help answer the question?
I think it does. If there's any follow-up,
Okay.
then what we can do is have you look that up later, and then we can get it out to the group
Yeah.
after the presentation.
Yeah, certainly. All right, next slide, please. So as I kind of, the previous slide kind of talked about looking at, it was the meta-analysis of looking at doing, most of the time it's really targeted. I'm sorry, universal decolonization ICU patients. Can this also translate over to patients who are non-ICU patients? So this is a study the ABATE study that looked at that particularly. And interestingly, compared to the ICU population, it didn't really, that decolonization didn't really make that significant impact on the non-ICU patients. So, however, next slide, please. When you stratify the population and looking at the all the various patients, where it did have the benefit of decolonization had to benefit on is those patients with medical devices. Again, we're talking central venous catheters or anything that's been implanted in them. So which I'll kind of reference a little later about why some of the practice guidelines now recommending any patients with having a device, particularly like a venous catheter placed in, a decolonization is something that should be considered as a strategy to reduce healthcare associated infections. Next slide, please. Here's an article from the New England Journal that now, as we kind of went from ICU to the non-ICU patient, what about those patients who were discharged, who have MRSA and then got discharged? And remember, I had pointed out in a previous slide that the effect of being tested positive or screened positive for MRSA continues even after hospitalization. So this is an effort to look at how, if there is an effect when reducing, if decolonizing those patients will have an impact on reducing subsequent post-hospital infections and such. And what these authors have shown is that, yes, that the decolonized patients compared to the education group, which is just essentially instructing them to do good hygienes and such, has a noticeable difference in the freedom or preventing from developing MRSA or any infections. Next slide, please. And as again, there's just a significant reduction in this is about 15 to 20% reduction in the incident of being transferred back to a hospital. These are patients going to a nursing home who have been screened positive, but then decolonized, that their likelihood of getting rehospitalized after being transferred to a skilled nursing facility or nursing facility also goes down. So demonstrating that decolonization does have definitely have a benefit even after being discharged from the hospital. Next, please. Next slide, please. And this is a recently published study that looked at not just one hospital's attempt, but a region. So multiple hospitals with multiple skilled nursing facilities, looking at where the hospital, where decolonization started during the hospitalization and continued through after being transferred to a nursing home. Those hospitals who are participating in this program has shown a significant, next slide please, significant reduction, almost about 25% reduction in developing infection-related rehospitalization or just infection overall. So there is a lot of, and this is a really big study, so a lot of studies showing that decolonization of patients, in specific scenario and certainly after discharge have benefits in preventing subsequent infections and hospitalizations. Next slide, please. And because of that, the really compelling studies, Shea and IDSA, as well as APIC, has kind of comprised and updated their most recent practice guideline in their strategies to prevent MRSA transmission infection to include decolonization as a strategy for reducing healthcare-associated infection, and as well as subsequent discharge infections. So next slide, please. And this is kind of is again more specifically toward central CLABSIs. And so again, having incorporating a routine standardized practice of decolonizing and daily chlorhexidine bathing of patients in the ICU with a catheter is now become a very recommended practice for patients to reduce the incidence of CLABSIs in hospitals. Next slide, please. So now going back to what kind of original question is that, so we talked about the benefits of decolonization, but now going to shift a little bit to the nuances. And that's, so let's start with this, is just the antiseptics, because you can't just, there are very, interestingly, is that, well, there are only a handful of antiseptics have been used in these studies. So for those who have been noticing, have listed all what the protocol had been for all the different studies, and either intranasally they were either mupirocin or providine iodine, and for the topical it's only had chlorhexidine. So if you look at those, next slide please, there's really is that there's just only really three. There's only one skin and one for the skin and two for the nasal decolonization. And moreover, then none of these agents are specifically FDA approved for decolonization. So these are studies, and even though I kind of showed you those studies, many of the studies are using these products off-label for a different for the purpose they're not for indications that was what they were not originally intended. So, and then just to add to that a little bit more of this, is that there are no direct comparison of various antiseptic agents, although there's not only a handful here to compare, but just to let you know that we're really, when we're talking about decolonization, we're really only focusing on those two, mupirocin, providine iodine, and chlorhexidine. That's been extensively studied. Next slide, please. Which leads to the question, and this is one that I get asked fairly often, is what about Nosen, or what about this alcohol-based antiseptic? And Nosen is probably the more popular one that I get asked about. And so looking at, try to go, when I was originally asked about that, I was trying to pull up some references to look at how, where, look up some references that had looked at using alcohol-based antiseptic. I went to their website to look at some of their references and what they're used to make claims. And so just to kind of start is that most antiseptic, these alcohol-based, are around about 60 to 70% alcohol with some with a benzalkonium chloride as a stabilizing and an additional antiseptic agent. Now, as for all the references to look at how well this works, there's only really 4 that were peer-reviewed. The rest were all either oral or poster abstracts. And so it's such, and so to respond, to answer at least a comment to my fellow IPs about this, whether should we use this product or not, especially how it's being marketed, particularly that it's doesn't have the concern that mupirocin has regarding the resistance. It's a lot easier to apply. It's not goopy like mupirocin, which is in ointment form, or kind of staining like the providine iodine. Patients also have reportedly really find it much more pleasant because it has that citrusy smell. So there is a huge, and so much of the marketing has been focused on the pleasantness that the patients experience and the easy of application by healthcare personnel. But not, again, without those substantial number of peer review studies, really none of the practice guidelines have actually endorsed using this alcohol-based or any alcohol-based product as an option for nasal decolonization. Next slide, please. Another question I get also asked is, and this is something we get on quite often because is what about that an alternative to chlorhexidine, and especially in those patients who are maybe have had have reported adverse either allergy to it or that it irritates their skin as such, or they just can't get it, especially here in rural Montana. They stores may not carry HIPAA in their on their shelves. So and benzalkonium chloride had been commonly recommended as an alternative, and so which is probably the most common one that's uses this compound is dial soap, and so it is commonly used as an alternative, but it also but its effectiveness has not been determined. I was unable to find any studies that specifically can look at using dial soap or directly looking at dial soap to compare to chlorhexidine to see if it's comparable. So not saying that you can't use it, but but again, if this is the only thing you have, then you do what you have to do. But again, it's important that they're not to note that benzalkonium chloride is not the same as chlorhexidine. So next slide, please. And just this is, as I said, there was no study comparative. This is the only thing I was able to find have anything that look at the two. And this was just a study to compare chlorhexidine to benzalkonium on the skin. And essentially what they did was they applied that to a skin and they swabbed the skin and see if there's an appreciable decrease in bacterial count. And it showed that that chlorhexidine was actually better than benzalkonium chloride. But again, what does that mean? Does that mean it's an inferior product? We shouldn't use it? No, because again, there's no clinical trial that looked at this using benzalkonium for decolonization. So that's still up in the air. So next slide, please. Yeah, so just a couple of more slides and just want to kind of limit some of these. You can keep scrolling down because they're all single points. Yeah, so as I mentioned, there are no standardized decolonization protocols. So if you decide to try to employ this protocol to do decolonization at your facility, there's no one way of doing it. And that's actually one of the reasons I listed what each of the study did is that to demonstrate that there's no one way of doing this, but also that you may, if you consider these are what's been looked at. As I mentioned earlier, most of the studies are focused on Staph aureus, targeted. So this is only really what they call vertical decolonization versus horizontal, which means they encompass other pathogens. Now, there are some studies that looked at gram negatives, as I mentioned earlier, but and it seems like decolonization may work in those situations. But again, there are just a very small handful of those studies. So whether should we do this to reduce, let's say, something like carbapenemus resistant Enterobacteriaceae, it's hard to say, because again, there are no great studies that kind of support that practice. Decolonization, again, can be logistically challenging depending on the settings and what resources you're at and such. And so, again, you have to do most commonly is what most places do is the nasal decolonization. But if you're incorporating also topical one, then you're having to kind of coordinate that, make sure that the nursing staff were trained and encouraged patients to do it, because most of the time it's more of an opt-in process, and patients can refuse. So for it to be effective, it has to be done consistently and appropriately. As I pointed out earlier, next item is that there's only a handful of antiseptics. I looked at it, so it doesn't really kind of, you don't really have a whole lot of options besides the mupirocin, propionyl iodine, and chlorhexidine. So, but anyway, there are some unresolved issues, and I think that this is something that would, as they're going to be, they're being actively looked at. Is what is the best? As I mentioned, no standardized decolonization protocol, but hopefully we're going to have something that will, in the next few years, that will guide that. This is probably the best one. That there is a question that pops up: chlorhexidine cloth versus soap, which is better? Does it matter? And this is where it kind of get down to splitting hairs and such, because I know that manufacturers are trying to point out that the soap, that the cloth may be better than the soap. But it really comes down to, does it really matter? Again, there's no direct head-to-head comparative study. Just because one is lower than the other, does that mean it's not the one that doesn't have have lower bacterial count is not as effective? It's hard to say. And again, getting chlorhexidine cloth is a little harder than getting the soap, as that usually the cloths are hospital or issued, versus the soap you can kind of buy that in the store. One popular thing is does MRSA coverage is needed if you do decolonize patients? And this is something that we have actually had debated with our orthopedic surgeons who recently started a universal decolonization protocol. A number of studies have actually looked at surgical prophylaxis to eliminate the need for using vancomycin as for anti-MRSA coverage, because many of the protocols don't involve screening patients. So if you don't, and since we don't advise using vancomycin in patients, in all patients, does it really need since we are not recommending vancomycin for all patients, regardless of MRSA coverage, there's a kind of a concern. So far, many of the studies have shown that using cefazolin as surgical prophylaxis in patients who have been decolonized, it has not resulted in an increase in surgical site infections. So, we talked really briefly about the mupirocin, and there are also some discussion about chlorhexidine resistance. What is that? Is that the significance in that? Keep in mind, most of the time, well, depending on the situation, if you're repeating, such as surgical nursing home patients where you're repeating the decolonization over a period of time, I can see that as a concern, but not all hospitals are practicing it. Certainly and those are just a handful that, who are participating in those studies. So it's still unclear what would be is there any sequelae to that? And is there any comparative studies? Not at the moment. So can't really prefer one over the other. A lot of times we end up doing it out of convenience or choose the product that has the most data in. And then finally, and this is a very popular question that comes out, if we decolonize patients, do you need to put them in contact isolation or contact precautions? And the idea, and certainly in places where do universal decolonization, they have chosen not to do this because they're not actively screening those patients anymore. So everybody gets treated as if presumptively for MRSA. So yeah, so I think I think they're leaning toward is no, but I think that they're going to be, hopefully there'll be more and more data to kind of support that likely that decolonized patients don't need to be in contact isolation. And I think that's it. Right. So just 3 quick take-home messages. I have not kind of emphasized decolonization as as a strategy, but I want to also emphasize that this is not a replacement of your existing infection prevention practice. So really kind of focus is that this is something that you may want to consider using to help enhance your current system rather than replacing. certainly implementation will require resources because of for all the reasons, getting the antiseptics and coordinating with the nursing staff and such, and making sure training the nurses and those who are going to be using these products appropriately. And there's still a lot of study research looking at for the best protocols and antiseptics. So hopefully, what I tell you may change actually in the next couple of years as there hopefully more of those results come from the research are available. Next slide. And I think that's it. Any question? And I think I just saw one.
There is one there, but so it's when do you think we may have some standardized protocols for this practice?
That's a very good question. One of the leading researcher in this field is Susan Wong and Mary Hayden. I'm actually hoping to run into either of them at the upcoming ID Week conference, and certainly will ask them that question because again, I think that they've taken that first step to get SHEA and IDS and APIC to kind of agree that decolonization is something that we could they're going to endorse. So that's going to be the natural next step is how do we formalize this? And now there is some talk, and I think they kind of highlighted about the mupirocin and the chlorhexidine baths. Yeah. And so I think that's probably what's going to get standardized is the mupirocin, the twice daily mupirocin plus the daily chlorhexidine bath. So
Perfect. And then there's a couple more coming in. We have some levels of care put patients with MRSA colonized in NAIRS isolation precautions. Other levels of care do not. Why is that?
Some level of care put patients in MRSA. I don't know. And this is where that's one of the things I kind of pointed out about what do you do with decolonized patients? Do you put them in isolation out? Why do they do it? Partly it is because CDC has not officially made any comments about decolonization as part of what to do in those situations. And and although I will say that HICPAC, for those who are not familiar with this, that's the Healthcare Infection Prevention and Precautions Advisory Committee. They're looking into updating their 2006 recommendations. So hopefully there will be something they're going to talk about about this, since there are now more data available. So hopefully more to come with that.
Okay, and then there's one above. I think you may have addressed it, but should non-ICU hospitalized patients with hospital lines have regular showers, baths, using CHG or use CHG wipes if unable to shower or bathe?
Oh, let me see.
It's from Andy Beck at 305.
Oh, further back up. 305. Oh, should non-ICU hospital patients with lines? Yeah. Again, it's one of those things that has not been very clear about protocols. I think many of those chose not to, and they're just using chlorhexidine cloths in lieu of actually soap, and then and then a shower afterwards. Now, I do want to add, and I didn't go into details about this, but so I think that the chlorhexidine cloths are being favored because is like when they're wiped, they stay on the skin, as compared to chlorhexidine soap, where the effectiveness requires the soap being staying on the skin for a period of time before being rinsed off. So I think that's kind of maybe why we're kind of really favoring the wipes, because they stay on, and so the effectiveness will persist versus you have to take that extra step of keeping that soap on you for a period of time before rinsing off, which probably most people don't do. So
perfect. And then I think there's one more of, at my previous hospital, we had started giving daily CHG baths to all patients with central lines, not just ICU patients.
okay.
Do you have anything to go off that statement?
Nothing to say that that's wrong. Again, it goes out to is those studies are kind of focused on those little populations I kind of pointed out. I think that again, more data comes out, whether I surmise there's going to be more and more data to look at bathing and hygiene as a crucial element to preventing hospital-acquired infection. Aside from those who we just pointed out, right, those with lines and such. I think that's kind of where we're going to be. Now, I think that also look at that this is also an extension of those patients who have been discharged and who continue to get decolonization. They have great benefits. So I think that's going to be, eventually that's going to be probably the focus is we're going to try to ensure that every patient have practiced very good hygiene to reduce their complications from their hospitalizations.
Perfect. Any other questions or any other comments that you guys would like to go over with Dr. Koo? I think you're almost beating the record. We're at 16 minutes over.
I do want to point out that we will have the slides and the recording linked on next week's reminder email that goes out on Wednesdays. So that will be there, and also it'll be posted on our website. So if you guys did want to re-listen, if we went a little fast for all the content that we covered, you definitely can listen to it at your leisure. And then next week, we will have a sepsis journey, barriers and successes for our region, presented by some Mountain Pacific staff. So we hope you can join us next week. We do want to thank you all for staying on after. We really appreciate your dedication. And we want to thank Dr. Koo for his presentation, and hopefully we can have him back for a few more topics arise. So you guys all have a great afternoon.